Hi, this is Brian Kim. I want to share with you this case of a patient who was referred from out of town. This patient is post-hyperopic LASIK, and she didn't want to wear glasses after surgery. And so she was referred, and we had a long discussion about her options, and we finally landed on the Symfony EDOF, Extended Depth of Focus lens. Unfortunately, immediately after the surgery, she was very unhappy with the quality of her vision. She felt like she couldn't see very well at all distances. And in my experience, these patients don't tend to neuroadapt over time. And so we made the decision to take this lens out and replace it with an LI61AO lens. This is the narrow blade speculum. You can see great exposure. You can see how easily I'm able to open up my incisions, the main incision and the paracentesis incisions. Again, this patient had surgery just a couple of weeks ago. That was intracameral epinephrine. And then I was able to place the dispersive viscoelastic underneath the rhexis edge and into the bag. And then getting underneath the lens with some cohesive viscoelastic and pushing a dollop of viscoelastic to push the posterior capsule back so that I can take the lens out. So IOL holder in my left hand, scissors in my right hand. But I'm going to first switch and place the haptics into the angle, inching my way towards the position that I want to cut it. Again, pushing some more cohesive viscoelastic to push the posterior capsule back. I definitely don't want to cut the capsule. Cutting the lens completely in half with the scissors, making sure I don't cut the capsule. Disengaging the forceps on the left side. Grasping the right side piece, pulling it out, and the haptic collapses on itself. Turning the second piece 180 degrees, grasping the cut edge of the optic, and in this way, when I grasp and pull the cut edge, the optic and then the haptic collapses on itself and comes out. Pushing some cohesive viscoelastic to fill the bag. This is a 2.4 millimeter injector, delivering the leading haptic into the bag. It points down, but then as the optic comes out, it turns back nice and plain. Optic is delivered, and then withdraw the plunger, and then deliver the trailing haptic. Removing the viscoelastic within the bag, underneath the lens, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had hyperopic LASIK. She was insistent on not giving up on range of vision. We decided to put in an EDOF lens. This patient was very miserable from day one, not very happy with her vision, very disappointed, very frustrated. And so I had a long discussion with her about the different lenses and how trying to go with a multifocal lens, a trifocal lens, another EDOF lens probably doesn't make any sense, because of the level of aberrations in her vision. Again, numbers-wise, her vision wasn't that bad. It was around 20/25, but she just felt like her vision was worse and she couldn't tolerate it. So going with a zero aberration lens with the LI61AO lens was probably the best choice. You saw how easily I was able to open up my incisions, placing dispersive viscoelastic within the bag peripherally, getting underneath the lens with a cohesive viscoelastic, popping both haptics up into the angle, positioning the lens and rotating it with 2 forceps so I can cut it in such a way that the haptic was just right side of my cut, and therefore I'm able to pull that right side piece out, twirl the left side piece out, and then pull that out as well. And I do it that way so that the haptic can collapse on itself, minimizing any potential damage to the cornea. And this patient did quite well. She was very happy with the vision. The quality of vision dramatically improved. Of course, she had to give up on the notion of having good range of vision. But until we have a lens that does not cause aberrations while giving range of vision, I'm grateful that we have a lens like the LI61AO for these patients. So I hope this was helpful to you, and I thank you for your attention.